Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and we're joined by our third host, Dr. Mike Clifford. How are you, Mike?
I'm good. G'day, guys. How are you?
Yeah, good. Good, thanks. Sick of the rain.
Yeah, Mike is enjoying beautiful sunshine outside his Victorian house.
In Melbourne?
Yeah, it's sunny here. Obviously, the vortex of rain in Sydney and Brisbane has sucked all of the clouds up there, and the sun is finally shining through on Melbourne. It looks quite extraordinary, all the colours.
Oh, man, I think I've forgotten what it looks like.
In this episode, we are going to discuss about a trauma patient in intensive care unit and around the coagulation pathophysiology and some of the pharmacology. So, Maddie, we got 32-year-old young male patient admitted to intensive care unit with significant polytrauma, and he's bleeding. Your registrar is curious to know a bit more about the physiology of coagulation cascade. Can you tell us about the coagulation cascade?
Sure. So the coagulation cascade is an amplification process, and it consists of sequential activation of a series of clotting factors, which produces fibrin to reinforce the initial platelet plug that's formed. Traditionally, it's thought of to consist of two branches, the intrinsic and extrinsic branch, which form to join to form a final common pathway. So just briefly, the intrinsic pathway is thought to be activated by contact of blood with a negatively charged surface, such as collagen. This interacts then with pre-kallikrein and high molecular weight kininogen, which activates factor 12, then factor 11. Factor 11 in the presence of factor 8 activates factor 10, which is then the start of the common pathway. The extrinsic pathway is activated by tissue factor, which then activates factor 7, which then goes on to activate factor 10, and that's as well as reactivating factor 9, causing activation of more factor 10. So both pathways converge on a common pathway, and this consists of factor 10. And some people like to remember it like X marks the spot. So that's where the two pathways converge. And then this in the presence of factor 5, which you can kind of remember because factor 5 in Roman numerals is a V, which fits into the X, which is factor 10. So 10 and 5 together converts prothrombin to thrombin, which is factor 2A. And thrombin then converts fibrinogen to fibrin. Thrombin also activates factor 13, which helps to stabilize this fibrin clot through cross-linking, and it cleaves factor 8 off von Willebrand factor and also activates more factor 5, 8, and 11, thus helping the amplification of the fibrin clot. It's important to know that calcium is a very important part of this coagulation cascade and is required for activation of multiple factors. And even though we traditionally think of the intrinsic and extrinsic pathway as the two pathways leading to the coagulation cascade, this is actually thought to be more relevant for things like in vitro blood tests rather than actually within the human body itself. It's now thought that actually the exposure of tissue factor at the site of injury is the most important thing, which activates factor 7, traditionally part of the extrinsic pathway, and that this is the primary event in initiating clotting. And this process then causes the formulation of a small amount of thrombin by activation of factor 10. And this thrombin then goes on to activate factor 5, 8, 11, and more platelets, which results in a rapid amplification of thrombin and thus a large amount of fibrinogen converting to fibrin, which increases clot stability.
Okay, Maddie, so you've mentioned intrinsic and extrinsic systems. What blood tests do we do to look at those?
So the extrinsic pathway is traditionally assessed by using the prothrombin time or more commonly the INR. Deficiencies of factor 7 will cause a prolonged prothrombin time, as this is part of the extrinsic pathway. Factor 7 is also a vitamin K dependent enzyme, as is 2, 9, and 10. So other causes of prolonged PT or INR, but a normal APTT include mild vitamin K deficiency, liver disease, warfarin most commonly, and paracetamol toxicity. And the intrinsic pathway can be assessed using the APTT. Factor deficiencies of 8, 9, 11, and 12 can cause a prolonged APTT, but clinically factor 12 deficiency isn't important and isn't thought to be clinically significant. Other causes of a prolonged APTT but a normal PT include von Willebrand disease, although it's often normal still, heparin use, antiphospholipid antibodies, and the presence of inhibitors to factor 8, 9, 11, or 12. It's also important now that we think of some of the new anticoagulants, direct thrombin inhibitors such as dabigatran can cause an elevated APTT, but it cannot be used to determine the drug level. And then if we think about the common pathway, so from factor 10 onwards, the factor deficiencies of 5, 10, prothrombin, fibrinogen, or a combined factor deficiency will cause a prolonged prothrombin time and APTT. And other causes of this would include DIC, severe liver disease, supratherapeutic dose of anticoagulation, severe vitamin K deficiency, acute leukemia, or any other cause of DIC like snake bites and post-thrombolysis.
You mentioned INR, Maddie. What's that stand for?
So that's the International Normalized ratio. So it's basically looking at the prothrombin time and comparing it to a normal population so that it doesn't have standard units. So like a normal INR would be 1, but sometimes if we're trying to anticoagulate patients, say, for example, warfarin, we'd look at having an INR of like 2 to 3.
And why do we use it?
It's more standardized. So it's standardized for different, I guess, patient populations, and the test is more of a standardized measure compared to the prothrombin time.
Yeah, so it's a way of standardizing your test to the local donation, so that if you travel around the world on your warfarin dose, when they do your INR, your blood gets, the effect is standardized against the local population, so the number is meaningful. So that the coagulation story, because it's almost started with testing before they knew what was going on, there's a tremendous amount of really interesting history. So I've got 2 questions for you. The first one is, what's factor 4? And the next one is, why Roman numerals?
The factor 4 is calcium, isn't it?
Yeah, good. Yep, factor 4 is calcium. And why Roman numerals?
Is it because the coagulation cascade was invented by some Roman scientist? And
you're on the right path. The hematology convention was in 1960 and it was held in Rome. So when they went through the list of the different things that people had found around the world, what are we going to call factor 1? What's factor 2? What's factor 3? They just defaulted to use Roman numerals. So that's the only reason that all of these textbooks have to have Roman numerals, is because the initial conference was held in Rome in the 1960s. And then all the factors were given names. And factor 6 turned out to be a factor that someone else had called something else. So it actually didn't exist. So they got rid of factor 6. So that's why there's no factor 6. And they just renamed factor 4 because they finally worked out, that's calcium. And it's a little bit like looking now at what is, tissue factor, and going back and saying, it's actually probably just a little bit of the phospholipid membrane of the platelet, which we've always knew you needed to add into the system to make it work. But now we know what it is. And that's why the platelets come into view. So it's just taken us a long time to work through the history. But there's lots of wonderful little things in the coagulation.
So if we move on, this trauma patient is bleeding significantly, and you've asked your registrar to perform a ROTEM. Can you tell us a bit about what the ROTEM is and how to interpret the results?
Yeah, sure. So that's a good question, isn't it? I mean, and often we do these intrinsic and extrinsic pathway analysis using an APTT and an INR or prothrombin time, and that blood has to go off to the laboratory to be processed, and that'll take a little bit of time. So what we would love is a point of care test that tells us exactly what's going wrong. It's interesting, isn't it? I mean, we don't do a lot of tests in the primary syllabus, and I guess that coagulation is one of those things where the physiological description of the coagulation pathway is almost defined by the testing that we do. So we have tests for the so-called intrinsic and extrinsic pathways, and we do tests that are to validate those arms of the coagulation cascade. So it's one of the areas of physiology where our testing is actually define the physiology. And then most recently, in the last 20 years, the physiology was upended when people started to describe the cell-based theory of coagulation, which we don't formally test, so-called. But it's a good question, isn't it? I mean, obviously a trauma patient, what's hemostasis? And I guess in this instance, you've got your basic investigations, which would include a full blood examination, which gives you your platelet count. You've got your normal coagulation tests, and we can send those off. And one of the issues, of course, is that will take time for them to be processed and get a return, but we'll have a prothrombin time and an activated partial thromboplastin time, which will test the extrinsic and intrinsic pathways specifically. You mentioned ROTEM or TEG, and that's an interesting test, and we have asked about that in the SICM primary exam, and hopefully candidates will have worked in a unit where that device has been available, the so-called point-of-care testing. It's increasingly being used, and I guess we're still trying to work out what role that test has. It's certainly popular as a way of reducing blood product exposure in cardiac surgery, but it hasn't really made prime time elsewhere, despite a lot of enthusiastic looking at it. And I guess if you take a step back, it's a sort of test that makes sense, really. It's a whole blood test, and it aims to test the functional strength of the clot as it formed. And there's two basic systems, as you've mentioned. There's a TEG and a ROTEM. And in that system, in the TEG, you've got a little cup with whole blood that spins against a fixed wire. And as the clot starts to form, it creates a tension or a viscoelastic tension that starts to pull on the wire. And that the amount of that tension that is developed is registered by the machine, and a visual assay is provided for you, and that has both numeric values as well as a sort of a graphical representation of that sort of clot tensile strength. In the ROTEM, very similarly, except the cup state of blood stays stationary, and what rotates is a pin within the clot. So the amount of torsion on that little pin as it turns creates the same sort of information, and the graphs that are generated by the TEG and the ROTEM are very similar. The latest generation of TEG6 actually uses the oscillation of the meniscus as the clot forms, and uses ultrasound or light to generate the information. And it's the same sort of information, how much tension is in that clot as it's formed. So essentially you end up with a graph that looks a little bit like a tadpole. There's a small line leading to the start of a opening up of the tadpole, and then the tadpole has a maximal width, and then the tadpole starts to form a tail. So the test is designed to have the initial phase, which is sort of the initiation of the clot within the cup, and then as the wire tension starts to increase, you get the clot kinetics, how fast that clot is forming, and then finally how wide that maximum tension is the clot strength. And as we have in all blood components that will start to break down clot, you get lysis of the clot, and how much of that fibrinolysis occurs will determine how rapidly the clot now and the graft disintegrates towards the tail and back to the baseline. And the test itself has numeric values given to each of those components. So the time taken for the graft to start to change from the baseline is the R or CT time, depending on TEG or ROTEM. And then the rate of which the graft changes, the angle, is a function of the kinetics and of the proteins that are available to you. So that's called the angle or the alpha angle. Then you have an area which is your maximum amplitude of the graph, which is the MA in the TEG and the MCF in the ROTEM, but they're essentially the same thing. And then you've got your lysis times, where the clot breaks down, and whether or not your device uses a lysis at 30 or at 10 or at 60 minutes, you'll have a different value for that. And those numeric values will be displayed on the device along with some normal values. So that's the principle of the TEG. And I guess the benefit of it is that it is theoretically quicker to get a result back, because you're starting to get changes to that graphical trace within 5 or 10 minutes, assuming that you are starting to form clot, which is usually well within before the time that you're getting blood back from the laboratory. So it's an opportunity to at least give you some information about deficiencies of clotting factors fairly early, and the rate of change of the clot and the width of the clot gives you some assessment of your platelet function, which may be distinct from your platelet count, particularly if your patient's been taking any sort of antiplatelet agents that will show up in the TEG test, which wouldn't appear in any of your normal coagulation tests, because we don't normally test for the functional activity of platelets. And the third thing in this particular patient, where he's a trauma patient and we are concerned about the presence of fibrinolysis, which is actually not that common in trauma patients, but in the sicker trauma patients, it is more common. And in patients who die from traumatic bleeding, it is very common. So it's a marker of severity, if you like. But you'll start to see thrombolysis appear on your TEG or your ROTEM, whereas that test may not be available to you from the laboratory unless you get a result in your coagulation that your fibrinogen is very low. So that's pretty much what the TEG and the ROTEM, how they work, what the functional components of their assays are. And I guess for the second candidates, there are plenty of examples of that basic trace online for you to look at. And even in Power and CAM, there's a small image which has got the normal looking curve as well as some examples of what deficiency states look like with the different sort of curves. And it's a pattern recognition sort of system. Once you've seen an abnormal trace on the TEG system, you can predict what the abnormalities of coagulation are.
Yeah, that's correct. So I guess it's very useful to understand the principles behind TEG or ROTEM.
The other thing to remember is that, like any test, if you don't really know what the test is or you've never seen it, it's good to remember that all tests have there's an indication for their use. There's almost always the physics behind it. So we talk about any of the monitoring systems. There's physics behind how those pieces of equipment work, and this is no different. The principles of the turning wire or the turning cup against the increasingly sticky fluid as blood clots you can get your head around that fairly quickly. And then what a normal trace looks like and what abnormal traces look like is sort of getting into the end of the syllabus, because you're starting to get into sort of pathophysiology or clinical disease states, which is not really what the primary exam is for. So it's better to try and understand what the normal curve looks like and what the components of that normal curve are, because then the examiner can just say, well, so if you didn't have platelets, what might the curve look like? In the same way that we might say, well, if you had an excess of adrenaline at this stage, what would happen to this trace? So we can use it as a bridge to walk off rather than expecting you to know, tell me what happens when you've got factor 9 deficiency, which we wouldn't do to people because that's not part of this syllabus. That's something that you might come across in your clinical exam, in your exit exam for SICM.
Yeah, that's correct.
What you can add to that is, well, what are some of the deficiencies of the devices in the same way? Why might a pulse oximeter not work? The problems with these point of care testing is they haven't been validated by hematology laboratories to be as robust as their own internal tests. So there's still a concern out there that they're not really measuring what we're trying to measure. So there's sort of a political difference in how they're viewed. Particularly the earlier devices of ROTEM and TEG required a lot of calibration and monitoring and maintenance. So they're not without the need for a fair amount of care, particularly if they're going to be used on the unit. That's improving now that they've moved over to sort of cartridge-based systems where they're a little bit more predictably robust. But then there's the analysis side of things, that the numbers that are abnormal and then what you do about those numbers is actually that's where the art of it all comes in. So rather than trying to treat abnormal graph traces on your TEG or your ROTEM, you're still expected to try and understand what principles are of treating any sort of coagulopathy with your blood products. And the TEG is a system, or ROTEM is a system that guides you towards those same principled outcomes.
Yeah. Absolutely.
So we've mentioned that this is a trauma patient, and one of the things that's changed recently, particularly because of this concern of fibrinolysis, is that we're starting to use antifibrinolytics. And these days, as a result of some very large trials, we're now almost routinely seeing patients come into ICU receiving tranexamic acid. So I wonder if you could tell me what is this tranexamic acid stuff that all these patients are on, and how does it work?
Yeah, so just to put it in a very simple words, tranexamic acid is an antifibrinolytic agent which is used to reduce the bleeding in various different settings. Now, just a little about fibrinolysis as a process. It is a highly regulated process composed of cascade of reactions to limit clot propagation. And inactive precursor proteins are converted to active enzymes, and which ultimately culminates into fibrin degradation by fibrin-specific protease, that is plasmin. Now, the principal mediator of fibrinolysis is plasmin, and which is generated from inactive plasminogen. And then plasmin generation is most often initiated by the release of a tissue plasminogen activator or urokinase from the vascular endothelium. Then thrombin also is a potent stimulus for TPA synthesis, and other factors which play a role in fibrinolysis are factor 12A and callicorin. Now, the way the tranexamic acid works, it is basically, as I said, it's an anti-fibrinolytic agent, and it was first made in 1962 by Japanese scientist pair, Shosuke and Utako Okamata.
Those two names will be on any short answer question, so we'll get the candidates to remember those.
That's right. But actually, the whole scientific history is quite fascinating. Anyway, so the indications for tranexamic acid are major trauma, then cardiac, orthopedic, and obstetric surgery, hereditary angioedema, pulmonary hemorrhage, GI bleeding, and post-tonsillectomy bleeding. Now, in terms of the mechanism of action, as I said, it is a synthetic analog of the amino acid lysine. It serves as an antifibrinolytic agent by reversibly binding 4 to 5 lysine receptor sites on plasminogen. This decreases the conversion of plasminogen to plasmin, preventing fibrin degradation and preserving the framework of fibrin's matrix structure. Tranexamic acid has a roughly 8 times antifibrinolytic activity compared to epsilon aminocaproic acid, ICA, which used to be used before in cardiac surgery quite a lot. And tranexamic acid also directly inhibits the activity of plasmin with weak potency, and it can block the active site of urokinase plasminogen activator or UPA with a very high specificity. So tranexamic acid also has got some anti-inflammatory activity. So that's why it's also commonly used in cardiac surgery. In terms of its pharmacokinetics, the absorption, it rapidly absorbed after oral administration with a peak plasma concentration after 3 hours. But in ICU, we most commonly use in intravenous formulation. However, topical use of tranexamic acid is not uncommon and can be used on the cutaneous bleeding or during the bronchoscopy if there is a pulmonary hemorrhage. Now, the dose of the tranexamic acid is variable. Usually is 10 milligram per kilogram, followed by an infusion of 1 to 5 milligram per kilogram per hour. Just to keep it in simple and just to remember, 1 gram loading followed by 1 gram over 8 hours for adult. Now, the bioavailability of tranexamic acid is around 45%. It has got a large volume of distribution with a low protein binding, and its elimination half-life is around 2 hours. It is normally excreted in urine unchanged. It also eliminated by hemofiltration or dialysis, and that's why it's important to reduce the dosing of tranexamic acid in the patients with renal impairment. Now, in terms of its adverse effects, it can cause nausea, vomiting, headache, and dizziness, which is probably the most common side effects. It is also known to cause hypotension. Systemic thrombosis, although its antifibrinolytic agents are quite rare. Having said that, it is notoriously associated with increased risk of seizures, and it can have increased risk of developing allergies. There is also one rare side effect, which is the transient disturbance of color vision. And there are a few case reports available on that, but not very common. In terms of the precautions that you will take, so just talking about some of the subpopulations, like pregnancy, it is normally categorized as a category B drug, and it is safe to use. And mostly in postpartum hemorrhage, we use tranexamic acid, and it has been shown to reduce the mortality as per woman trial. Only small amount of tranexamic acid appear in the breast milk if taken during lactation. So if it is required for any other reason in breastfeeding females, it's quite safe to use so. As I mentioned before, in the kidney impairment, tranexamic acid is not well studied. However, due to the fact that 95% of the drug is excreted unchanged in the urine, it should be dose adjusted in patients with renal impairment. In liver impairment, dose change is not needed as only small amount of drug is metabolized through the liver. And in terms of evidence, to recap, I guess the CRASH-2 trial was the major trial which suggested decreased mortality in patients with trauma. And since then, we've been using tranexamic acid, 1 gram bolus followed by 1 gram over 8 hours, even starting as a pre-hospital intervention in major trauma or polytrauma patients. Then there is a CRASH-3 trial, which also showed reduction in or benefit of tranexamic acid in patients with traumatic brain injury. And again, a woman trial, as I mentioned before, has showed significant benefit with mortality in patients with postpartum hemorrhage. So the tranexamic acid has been listed now as one of the essential medications according to WHO. And I think it's not uncommon. It might be expected from primary candidates to know a bit more about tranexamic acid in exam.
Yeah, that's fair enough. I mean, and we also have increasingly we see patients who are on extracorporeal life support who can develop a fibrinolytic state, often in the setting of sepsis or infection whilst they're on the circuit. And you not often, but you will sometimes use tranexamic acid to slow the rate of bleeding in those patients whilst you're sorting out the infection or getting things done. So we do see it in an increasing number of our patients in the intensive care unit. And of course, we deal with patients who have, acute ongoing bleeding who aren't going to theatre, like, gastric bleeding or bleeding from the kidneys or the bladder. It's interesting, the oncology patients who have hematuria, sometimes tranexamic acid is used, but there is an increased risk of intrarenal thrombosis in those patients. So you have to be careful. But, sick patients with low platelets counts are often in intensive care. And when they're bleeding, then tranexamic acid is one of those antifibrinolytics that we often use.
Absolutely. Thanks, Mike, and thanks, Maddie. So I guess we're coming to the last part of the podcast, which is going to be Maddie's section, Maddie versus Mike. So Maddie, do you still have...
Yeah.
Okay, go ahead.
I think this one's a bit more straightforward, but maybe I'm jinxing you. So why is the coagulation cascade so famous?
No, go on.
It is anti-something?
No, because it has the X factor.
Next time you have to come up with some better joke, Mike. So thanks, Mike, and thanks, Maddie. Thanks for your time. We'll be back in month's time with another episode. Till then, goodbye and have a nice time.
See you later.
Thanks for listening.